Thanks everyone for joining. We'll be getting started in about 2 minutes. While we wait to get started, I do notice that we have a number of Cindy Greens on, and I don't think that's because Cindy has joined 6 times or 7 times. I think it probably is because Cindy shared her link with somebody else. If those of you who are not actually Cindy Green would like to change your name so that we know who you actually are, you can do that by clicking on more by your name or on the 3 dots and just choosing rename. And if you're not sure which of the Cindy Greens you are, if you turn on your video for a minute, you'll actually be able to see yourself and you'll know which one is you. So feel free to change your name and then we'll know who people really are.
Hi, I'm Cindy Green. Can you hear me?
Yes, I can hear you, Cindy.
So that is my entire team, my case managers and social
Perfect.
workers. I just sent them the link.
Thank you so much for inviting them. We are very happy to have all of you, whether your name is Cindy or something else. I see Heather Jordan did the same, and we really appreciate you sharing the information with your team. It's just fine. It won't create any problems. But if you would like people to be able to know who you are, you're welcome to rename yourself. But same with Heather Jordan. Thank you for including your team. We really appreciate everybody joining and your interest in the topic. So we'll go ahead and get started. My name is Jeannie Monk, and I am with the Alaska State Hospital and Nursing Home Association, and I'd like to welcome you all. This is a really big day because this is our first official educational event related to the Alaska POLST. The implementation is just underway starting January 1st, and this has been a long time, many years in the making. So we appreciate everybody. We decided to begin the educational efforts focusing on the long-term care perspective and on skilled nursing facilities because we know this issue impacts you all significantly. So I'm going to introduce our speakers. First, we welcome your questions today. We do have a chat box. You're welcome to put questions in the chat at any point. If we are able to answer them in writing, we will. Otherwise, we will answer them at the end so that we can keep the presentation going. We will be posting the slides and the presentation, the recording on the AK POLST website. And so we'll be sharing that information where that will be in the chat. So now I'd like to introduce, we have 2 speakers. We have Charmin Figgenshaw. Charmin is from Washington State and has been involved in POLST for many years. She's part of the POLST task force and has been part of their effort to really advance the POLST process and advanced care planning in Washington. And we're lucky to have her involved in Alaska. The second person who is helping with the content today is Ursula McVeigh. Ursula is the medical director of hospice and palliative care at Providence Medical Group Alaska, and she has been very involved in the development of POLST and is very committed to the process and really appreciate her involvement. So with that, I will turn it over to Charmin. Thank you.
Thank you, Jeannie. I am super thrilled to be here and really want to start by giving huge kudos to this entire team. I really want to thank Dr. McVeigh for all of the work and for reaching out to me. I'm thrilled to be involved, but I want you all to realize who you have to thank, this work group that's been working on POLST education, especially the long-term care subgroup, Karen Mailer, Barbara Bigelow, includes Jeannie that we just heard from, and Dr. McVeigh and Marion Johnstone Petty, and many others. Jan Milet, certainly we have to thank for the design. It's exciting for me to see this group, especially since in Washington, we sort of built the program after the horse left the barn. So it's very fun to see a group that's putting so much thought and planning and real program development and to support you all as you get used to POLST as your new program. So I'm going to start by sharing just some of the goals today. We hope you leave with a sense of how POLST fits in to this overall scheme of advanced care planning. You should understand the difference between POLST and advanced directives. We're going to be sharing with you the POLST regulatory information, which includes what the form looks like, how it works, the orders it has, how it is honored, who are the candidates for POLST. And at the end, we'll have recommendations for that transition. We know that change is not always comfortable, but we're hoping to give you the support you need to make this something that will improve care for patients that you care for. I use this graphic to start. This is part of the Alaska basic information about what POLST is. And I think it's a great way to frame that POLST is really it's part of this bigger process. It also is really grounded in the foundation of a good conversation. And then, of course, when people talk about the POLST, they're usually talking about the form. So I hope you see, we'll spend a little time but I'm getting through the first two and then to the next one. Sometimes my cursor goes away, and here we go. So this process should look familiar to you. Advanced care planning is for every adult. It's about thinking what is important and who a person trusts to make decisions, having those conversations about what matters with the people about who are trusted. We know from research that people make better decisions even when they can make their own, when they're supported by trusted advocates. So we want to encourage those folks being involved early on and then writing things down so that a plan can be created that can be shared and followed. The job that will fall onto administrators and folks in leadership positions is really making sure that policies and training are going to be in place to support all of this work. I like to point out at this point what an incredible opportunity is to start advanced care planning if people have not had any before. When they are admitted into facilities, it may be their first time. And I like to talk about this as every time we start the conversation, we're helping titrate people's tolerance for being able to discuss their own wishes and talk in terms, sort of build confidence so they can talk to their families and loved ones, but also build their confidence to be able to bring up questions and express their wishes to healthcare team members. So any way that you can encourage and train your staff to be having these conversations will reap benefits, and we'll see more of that in a minute. The advanced care planning then is translated into documents with there being two main types. Mostly we're familiar with those legal documents, and Alaska's done a wonderful job about defining and creating documents that you use for those advanced directives. It includes both a durable power of attorney for healthcare and then those other health directives, directive to physician or living will. Those can be used to inform and should be consistent with whatever becomes our medical plans and orders. The POLST being this type of container, a medical order container for a person's wishes. And you'll see as we go on how it has a broader reach and can serve patients upstream of where Comfort One has typically been involved. Here's another table that talks about the difference between POLST and advanced directives. And I won't go into this very much in detail. It's a great reference and resource for you. I've think if we need to point out anything at all here, it's that an advance directive has to be completed by the person themselves. They complete it and they sign it. They can certainly consult with others, but it can't be completed by any kind of healthcare surrogate or legal representative, whereas a POLST is part of that medical plan. So the healthcare team is involved, the individual and surrogate can all be involved in discussing. While in Alaska, the individual doesn't need to sign it, they certainly can. And we'll talk about how that's recommended. But the signature that makes it an order will come from at some point, a physician will sign this order, but it may live as a verbal order also. And that's a really significant a point of flexibility for facilities that may have a nurse practitioner who visits regularly or a physician assistant. They are portable, and that's another really big essential part we're going to look at in a minute about POLST. I'm going to go on. And so the middle piece was the conversation, and we realized that's just too big of a topic to try to do in one, like all these topics together. We want to be presenting aspects of the conversation and the nuances of using and completing POLST as another webinar on the art of the POLST in skilled nursing facilities. I hope that we'll be able to draw other kinds of clinicians to this as well, because the skills training that are going to be built into this webinar will be important for everyone. So first we look at why are we even choosing POLST? And we have 25 years of use of POLST in other parts of the country to draw on. Actually, I was looking it up. I think it's going to be 30 years this year since Oregon launched their first POLST. If you go to nationalpolst.org, or polst.org, which is the national website, and look under their research, there's research that goes all the way back into the 1990s on POLST. But I pulled out a few things here to show that really POLST is so effective in making sure that the treatment that people can get matches the choices that they make. And that really it's easy to have consistent interpretation. And one of the studies showed that really no documented misinterpretation happened once EMS care was initiated following a POLST. The second two studies I want to point to, because these were specific interventions in skilled nursing facilities that increased the capacity of staff and the skill of staff to have goals of care conversation, showing how those led to increased documentation and the completion of POLST forms, and that when those were in place, the result was this reduction in preventable hospitalizations and total hospitalizations. So I hope that's inspiring. So I'm going to start by just letting you see really briefly that this 2021 POLST regulation, which is really managing or directing the movement from the Comfort One program to Alaska POLST. It puts into regulation the new POLST form. It includes a comprehensive reference guide and points to the fact that the POLST form will be this, the adapted national POLST form. So we're going to take a few minutes. There's one more slide that is a reference document, again, official. This is something that can go in the link that speaks more specifically to what POLST is, who it's intended for, who can fill it out, and who will be following it. And now we're going to move on to, though, that form itself and spend a few minutes really looking at what is in the form. The basic thing that you need to know about it is that it is medical orders that are portable. It's very unique in that way. Very few of our medical orders leave the facility. Usually they stop at the door of the hospital, or they're only active while the person's in a certain setting. But these really are meant to travel with the patient. And that's a really big functional part that you need to build into your thinking now, that people need to know that physical POLST form needs to be with the patient in order for it to be acted on where it's needed. It will guide emergency care across settings, whether the person's at home or they're in a facility or an LTAC or in an emergency room. It will give EMS those direct orders, unlike advanced directives or even most orders, which really are not legislated to give direct orders to EMS. It will be signed by a physician, although verbal orders can be taken by anyone licensed to take a verbal order. The individual and legal representative may sign it, which is recommended. Consent and discussion are verified as part of the order. And it's one of the things I love about the verbiage on this form is that the physician signing it is actually saying, I am promised there's been a good discussion that's backed this up. I can confirm that. So the nice thing about Alaska having adopted the national POLST form is the fact that it's going to be so recognizable now, which increases its ability to be honored in most states. As we drill down in and look at different parts of the form, this is the top half of the page, the first page. We see that it reinforces that it's a medical order. I have been working with POLST enough to know that every word on every POLST form has hours of thought behind it. Almost nothing ends up on this document that hasn't been discussed a lot. So I really think it's worth your time, if you're going to be using it, to sit down and read it carefully, really familiarize yourself with the wording. This is going to be a really top-level overview so that you know what's on it, but there's a lot of great content and answers to lots of questions that are baked into the verbiage here. You'll see the first section is for the name and identifying marks, but even things like the having POLST form always being voluntary is on the form. In section A, we see the CPR orders, which is a preference for the kind of care people want when death is imminent. In other words, the code status. But there's also that the initial treatment orders in section B, which is where people can express their preference for a level of care during distress. In other words, where do they want to be cared for? Are they willing to go to the ICU? Are they okay with hospitalizations but prefer not more aggressive treatments? Or are they wanting to be cared for at home? People can choose full treatment while they're alive and in distress and still say, I draw the line if my heart stops. So DNR in this case does not mean do not treat. You can have the full level of treatments available to you, even if you opt to be DNR. In the bottom half of this page, one of my favorite sections is the additional order section. This is where things like a preference for IV antibiotics versus oral antibiotics only might be put. I've also learned from some of your Alaska colleagues that this is where someone might indicate whether or not they prefer to be medevaced, or whether they prefer to stay in their community and have whatever level of care may be available, but not leave their community to be cared for far away from their family. There is a section for preference on medically assisted nutrition, which very importantly includes the option for a trial period. And I love that it's here on the form because it's helping us remember as clinicians to talk about things like trial periods and the difference between not having surgically placed tubes, but using, for example, an NG tube that might be in place during an emergency. There's also a box saying that no decision was made here. You can also note if the topic was not discussed because it didn't seem pertinent. I think that's a preference. Rather than leave this section blank, if you're not discussing it, it's okay to just write in not discussed. The signature section for the patient or patient representative also has verbiage that says if this is not the patient signing themselves, then at least it's been done with the knowledge of what the patient's wishes would be or in their best interest. Now, again, in Alaska, this signature is optional. I like to really encourage that recommendation that people sign it by telling people that it's going to be very reassuring to their loved ones as they're being asked to make decisions if they actually see their signature, that this was actually a decision that they made themselves. And you can see in the healthcare provider's signature, I've put in an example of how a nurse practitioner or physician assistant might sign this by just noting that they've received a verbal order for it. On the backside, again, I really love the completeness of the top section and how it describes the process that went on. It really confirms that there was a process, that advanced directives, if they were present, were used. It even has a place to note if there was a conflict that existed and whether or not the person was able to participate themselves or other people were involved. There's a place for the team members of the healthcare team who assisted in the conversations to put in their information as well. And that's super helpful because we know medicine is a team sport. One of the edits that you'll see that I've made on this form is how a nurse practitioner might take that box that says nurse and actually indicate their licensing, whether it's A&P or DNP, or just write the word practitioner in there. So someone knows if it was a nurse practitioner who was helping. The contact information below, the important thing to remember is that this section does not actually assign any powers of attorney for healthcare decision-making. It merely records the person who is in that position. Or it may be that no one has been chosen as a healthcare agent or representative, and this is the caregiver or the person who is closest to the person as an emergency contact. So sometimes you'll find multiple names in this area, and you can be clear about whether that person is actually a legal representative or whether they are an emergency contact. There's also room to indicate if the person's enrolled in hospice. This is probably the wordiest side. This has a lot of information and it's probably the least read part. Again, I'm going to go back to my recommendation to actually familiarize yourself with what is here. It has good guidelines for things like completing the POLST, it's honored and used, how to review it, how to modify or void it. The note here is that because these are medical orders that are meant to kind of live independently, if you're transferring these to some kind of internal orders, a person's being admitted and you have a different kind of order set that you're going to use for that internal process, you want to make sure those orders are consistent with the POLST. If those are changed, then a new POLST should be completed. But otherwise, the POLST can just be updated with new dates and confirming that the decisions stay the same. So now we're going to move on and just talk about the population that would benefit from having a POLST. And when we talk with clinicians, people who are used to, physicians who are used to doing prognosis, this is a new way sometimes for them to be thinking about it, is to ask themselves, would you be surprised if this individual died in the next 1 to 2 years, as a way of getting a sense of where that person may be. Now, it may be that they live for 5 or 10, But if you wouldn't be surprised, then it means that they're probably, living with some kind of serious condition or aging or frailty. I talk with people a lot who are not in that provider role and it's not part of their scope of practice to prognosticate, but especially in the settings of skilled nursing, long-term care. I think your staff, your administrator, you as administrators, or certainly as medical directors, but even your nursing and your admit staff probably also have that gut sense to them. So I would be training and encouraging people to use that about when a POLST might be offered, or at least when the information about POLST could be offered to someone as an option. Other things that may play in is if people have a condition where undergoing aggressive or invasive measures might leave them in a situation that's worse than where they are, reducing their overall condition or worsening their overall condition such that it would not be an acceptable quality of life for them. And the folks that we think about as we consider that are people with dementia, maybe even moderate dementia. But if they were to have that emergency, they may not want to have aggressive measures. Increased risk of harm might be part of their medical condition as well. I think about people with, an aneurysm or osteoporosis, where the harm from the procedures themselves might be onerous. Also, you may run across people who just as part of their personal values don't want to be resuscitated, don't want aggressive care. And we like to think about the shared decision-making model around that. I feel like it's important if the clinician is going to put their signature here, that they understand the person's motives for those choices and really take part in an open conversation. Again, we're going back now to that really high quality conversation as a basis for POLST. When we talk about people who are living in or coming in to skilled facilities, we often don't realize how many people they may come in for their hip fracture, but they may have diabetes, heart disease, they may have a prior cancer. There may be many things that qualify them for this serious or chronic illness category. Just want to think, not everyone who comes into a long-term care or a skilled facility for skilled care is going to need a POLST, but many will. And I think there are many people living in our long-term care facilities and skilled nursing facilities who could benefit, who may not have been offered one yet. So what about if people cannot participate in their own advanced care planning process and are not able to complete their own POLST form due to lack of capacity? This is another arena where when people enter into care, into a skilled facility, it's a great opportunity to help people really reconsider how they're doing decision-making. If they can make their own decision, we can certainly be helping them name that person so that in the future, they won't be faced with having decisions made by people that they may not have chosen. It's important to know that the top 3 levels here are, number 1, that person that's named in a durable power of attorney. So everything we can do to get people to name that and fill out that paperwork is going to give them the best control. I'm going to jump. Well, no, let's address guardian. So have had conversations about how LASCA directs what guardians can do. And I think it's gratifying to know that guardians can take part in helping people have a POLST form by non-opposition to a physician's recommendation, and that there's a formal process and a formal letter. If you're a guardian, I'm sure you know about this. You may or may not be aware of it. Probably are aware of it if you're administrator. But this is going to apply to completing POLST forms, that if the guardian takes part in that process and takes the recommendation of the clinician, of the physician who feels that whatever level of care, whether it be DNR or combined with selective treatments or full or comfort, that the guardian can have a position of non-opposition to that, so that the signing of the POLST form by the physician then is supported by that guardian role for the benefit of the individual. An individual who does not have a healthcare directive, does not have a guardian, can also choose an agent one other way, and that is to name a trusted decision maker verbally by informing the supervising healthcare provider. So if they're in your facility and they've said, I want you to call my daughter, I want her here making decisions. If anything happens to me, she's the one you go to. That can become their next legal person. In the conversations I've had, this is not true in Washington. So this has been a kind of a learning edge for me. My understanding is that each facility will need to have policies and a way to honor that. I think the potential is here, and maybe not completely worked out, but if that person then is named on the POLST form, indicated where that decision was made, to whom. So Jane person, my daughter, is going to be my person now. And I said that to the nurse practitioner at this facility on this date. It was co-signed by the doctor that was overseeing care. And that's on the POLST form. Then as the person transfers, that decision could be confirmed in each setting. The hospital could say, is this still correct? And it would live as a guidance document. So I think it's a great way for the POLST to help support this. I'm getting a little bit in the weeds here, so I'm going to try to move a little bit faster so we have some room for questions. And I see, thank you, Ursula, for putting the link to the information about surrogates. The only other thing I like to make sure people understand, and I'm sure you all do, about surrogates, if no one else is chosen in those top 3 levels, the spouse is the next. But then when it comes to adult children, even parents or adult siblings, all the people in that category have to agree, or they have to vote someone to make a decision, or they have to vote by majority rule what the care level will be. So I think that's a great incentive for people to know that choosing their own and making it official is a good benefit. The reference documents also talk about the Alaska law that requires all healthcare professionals to follow POLST orders. This is pretty much everybody. EMTs, first responders, anyone working in any of the healthcare settings, they'll comply with POLST orders, honor the completed POLST form as a medical order, and then be provided immunity from civil or criminal liability, which is really huge. This document also covers how to handle disputes. I'm not going to go into that here, but I think there's great language about how EMS will contact online medical control for, trying to get a simple answer to the dispute, understanding that sometimes it's just going to be necessary to transport someone to try to address the conflict in a different setting. And healthcare organizations are encouraged to really make sure that their policies cover who will be making these decisions in the case of a dispute. Let's see if I can get back here. Oops, I think I went ahead. So now we get to what it's going to look like. And first, I want to just reassure you that this transition from Comfort One to POLST is really going to have huge benefits for patients. It's going to combine the function of Comfort One with some of the in-facility orders that some of the orders that were only in facility orders like most forms. It's going to be applicable to more patients because it's not just been created for those folks who are choosing DNR, who are on hospice. It's going to have this applicability to a wider range. It ensures that patients are going to receive their desired level of care and communicates that in a way that emergency responders can get very quickly and know what to do, not just in code situations. So it really is protecting against unwanted care. And then it has that legal footing so that there are protections and protocols for portability. Now, I had to learn a lot about MOST in order to come here. And I was, one of the things I'll say is I was impressed at the thinking that went into the creation of MOST. And my understanding is that it could certainly have become the POLST for the state, but because it lives where it does and was not passed into a law, it's going to have some limitations, that the orders on it are not necessarily transfer. You can't really, most can't really follow a patient to different settings. And it might be signed by a provider whose orders can't be followed by EMS. So enter POLST as this new and improved MOST, recognizing that there's going to be a transition time for groups. It's important to realize that, oh, and I didn't mention this on my earlier slide, but I'll do it now. The POLST work group at DHSS is going to be continuing the Comfort One program for at least 6 months. So those will still be available. And those two programs will run parallel, POLST and MOST. They are recommending that because the biggest area of confusion might come because MOST sort of looks like POLST, they're really advising that MOST be replaced by POLST in skilled and long-term care facilities. For those facilities who really see that they need that other internal set of orders, the recommendation is to rebrand MOST. So there should not be any forms out there that say Alaska MOST. The Alaska statewide designation should go away. And those could be branded with an organization's identity, for example, whatever it may be, Regents MOST or whatever it may be. And then internally, those organizations will want to have policies for both using POLST in tandem with those in-facility orders, and may continue to need a policy for people who opt not to have POLST. I think it's really important to let people know when they're being admitted that if they want to be DNR and they want that status to be valid, if they have to be transport, that now they really are going to want a POLST to be able to travel with them and be that portable set of orders. I know this is a lot of information, and it might be a nice place to stop and just, Ursula, has there been anything in the chat that we should address right now, or are there any burning questions out there? I think we're doing okay on time.
Yep, no, nothing in the chat, but we could have people enter them in the chat or do a verbal Q&A at the end if nothing's provided in advance.
Yeah. We'll be, I'm going to go on to the next slide and we'll talk a little bit more about, so this is, how do you do your advanced care planning for how your facility is going to transition to POLST? And I think first it takes looking at the processes that you have in place. And this is going to be some work. You're going to need to look at, where do your policies refer to Comfort One? Where do they refer to MOST? What needs to change? How do your procedures that then your staff are going to follow, how are they being given direction? And then following that up, obviously, with good training, both with documentation and how to use what's there, but also the skills to help people understand what this new tool can do for them, and knowing who to even offer it to. So there's a lot here, and this work group is really working hard to support your work by offering these trainings. And we can certainly, be looking at what levels of support are needed next. This might be a good place to say, if you've got some interest in developing policies and developing templates for policies, you might want to join this long-term care subgroup that's working on education. And I encourage you to get a hold of Ursula or Jeannie to let them know that you'd be interested in sharing and being part of that. I think the policies also, part of your policies need to include regular review. You may have that in your policies right now, that you're reviewing people's wishes and you have ways of documenting. Just make sure those are updated. And then ensuring that the business end of this, that the clarity and the access and the way that you're going to honor POLST, whether it's in your facilities or during transports, is clear. And then, looping back is part of the training then, so that everyone in your facility knows what to do with a POLST, knows that when they're sending someone out, they need to have that POLST accompany them. My understanding is that I shouldn't say my understanding. There are states who have done this and have some nice templates and samples for policies. And I believe, Jeannie, were you going to put some samples from other states on the website?
We certainly could.
Yeah.
Or we can share them through other ways, but yes.
Yeah. There might be, a place where, resources about policies can start to exist, and you guys can build a resource library for yourself.
Absolutely.
I decided not to include those in this talk, even though, Jeannie, I really appreciated that you sent out the ones. I believe they were from Pennsylvania, and they're quite good. They are very detailed policies with step-by-step about how staff in nursing homes and facilities and skilled facilities and long-term care can really both be on the creation end of getting POLST in place for people as part of their advanced care planning, but also on the honoring end and have procedures for when people are transported.
And that Pennsylvania document is on the long-term care page right now.
Okay, good. That's great. I think you guys are going to be creating some good work that is going to become the sample work for other states that are not as far along as you are. So appreciate all the work you're doing. We're kind of getting near the end, and I always like to end with this idea of best practices. Most of these best practices are very general when it comes to POLST, and I believe Marianne's been working on making these best practices and also the FAQs we've talked about part of a toolkit that's available on your website, on the POLST website for Alaska. But just remembering that idea of POLST being not this separate just checklist, but it's really part of this rich advanced care planning process. I'm going to share a story of a couple that I've been seeing. I've seen them several times. She's actually younger than me, but with a lot of medical problems, and he's quite a bit older with also medical problems. And they both are quite adamant that they want to have a POLST form that says full code. Because even though I've shared with them, if you're going to be full code, that's standard of care, you don't really need to have that. And she actually looked at me and she said, people take one look at me and they wonder if they should start CPR on me. And I said, yeah, I get that. I wonder that too. But she says, it's absolutely the way I want to go. I want my family to know I tried everything. She may change her mind. I think she is on that road, but they understand that their chances, both of them, of surviving CPR are small. And yet they they want to be full code. What I love about them as this example is that we've started talking about it. The first time we brought it up, they didn't want to talk about it, but now it's a part of every conversation. And she's starting to talk about how terrible it was to be intubated and sort of measuring that against this other belief system that she has, that her family has to know that she didn't leave any stone unturned. So I want to just share that as a way of saying these conversations can open up really rich parts of a person's values and beliefs. And as you watch them and titrate them into being able to think about it and talk about it with their loved ones, you can actually see them questioning and moving from something that maybe they thought was a long-held belief into something more personal that they create for themselves. So I really encourage you to these best practices about really using high quality conversations to be the basis of all this advanced care planning can't be emphasized enough. We want to make sure that those POLST choices make sense. I think that your POLST form itself is going to help with that because it's so clear about matching yes to CPR with full treatment and yet allowing people to be DNR with any level of treatment. But we've had trouble in the past with people marking yes to CPR and then marking comfort measures, which really makes almost no sense. So that's something to watch out for. And I think as we talk about ensuring that POLST is accessible and creating those policies, I think Ursula is the one that said, it's going to be in all of our hands to just be on the lookout for how we can really make the best use of POLST, making sure everybody who needs to know about it knows about it, making sure that I'm thinking back to, Ursula, to our conversation about how Comfort One in the past has been held at the dispatch stations of the EMS, and POLST will not be. So in some ways, the management of POLST will be simply make sure the form is with the person. The current POLST form will always be on the AK POLST website. You won't have to order them. They won't be triplicates. There won't be a lot of things to track. You just go and get the most current form, make your copies of it. Whenever there's a new form or a revision, I know in Washington, we are just now at our 20-year mark and we've revised the form 7 times. So you always want to make sure that you're getting that most current form off the website, but it's quite easy to do. So in some ways, as you get used to this, it's going to make things easier and more streamlined. Have I missed anything? I see someone's asking about the color of the form. Yeah, I agree. We're very attached to our green form in Washington, the evergreen state, actually. But I also am having to lose my attachment to it because, quite honestly, they don't fax very well. The color really makes it hard sometimes to read. So I think the Alaska's decision to not have a colored form, to go with a white form, which can be reprinted on white paper, there's a lot of wisdom in that. I think EMS will learn. You may know Oregon has decided to put a pink border around their paper, but I think it just it's another level of complication to get special paper then, right? I love the white form, the idea that it can be, and you'll see in my next one, my next and last slide is about takeaway tips. And so I'll just move into that. My last recommendation on this is make a bunch of copies and give them to everybody. When someone's got a POLST form, my doctor friend at Peace Health says, hand them out like candy. Everybody involved with the patient should have it. But do make sure that you are making sure that the primary care and specialty care doctors have a copy of it, that it's in their charts, and that whatever the nearest sort of home hospital is for that person, that they have it in their file as well. And the hospitals will be gearing up to have POLST form, a place in their electronic chart where people can easily access POLST forms. I think Providence has been a real leader in making sure that their EMR has an easily accessible advanced care planning documents, including POLST. The other tips are just remembering everyone needs an advance directive. And the part of that that's most important is the naming of an agent. But not everyone needs a POLST. However, you in your facilities will see many people who probably should have one. You're going to be thinking in terms of that serious illness, progressive decline, frailty. We're also going to be thinking in terms of if there's a prior POLST, don't start over. Just review those decisions, confirm if there's no changes. You can make a new note with a new date on the POLST. In Washington, we actually have a section at the bottom backside for that review. It was not included on the national POLST form and therefore not on the Alaska form. As you can imagine, the real estate of that form is very precious. But I think it's also easy to realize it's like a script pad. You can just write things on it and make it so. So if you want to put an updated date on it, I think that's a great way to confirm that a prior decision has been confirmed. And then including those healthcare agents, the trusted decision makers or surrogates whenever possible. Family and surrogates tell us all the time that they really appreciate knowing that their decision is based on what that person has already said they wanted. So wherever you can facilitate that conversation in advance, so people can really come from a place of knowing, really helps. So, okay. We have about 10 minutes for questions, and I encourage you to just really share with us what you think your struggles may be with this, where you feel like you may need support or help. Anyone have any comments?
I told Charmaine that this was a group that asked lots of questions, and to be sure and save time for questions. So I'm counting on all of you. I'm curious.
Thanks, Cindy. Yeah, no, go ahead.
If this is new information for people, or if this is information you didn't know about.
I might share, there was one direct message question to me that I think people might be interested in. I'll pose that. A question came through the chat about the timeline about implementation. So when is this active? When do facilities need to transition most to POLST? And I started a response. I'll say that the state owns, DHSS owns by the statute and regulation, the oversight over the DNR program that was Comfort One and that now is POLST. The state doesn't have any ownership over most at this time. There was a task force that developed it, but it's not owned or doesn't sit in any DHSS organization. I think except for being adopted by the Pioneer homes that fall under DHSS to use that as their in-facility order set. So the state doesn't have a purview over how you're using the MOST form. The recommendation comes to transition to the POLST because probably what you're getting from the MOST form is what you were missing from a Comfort One. And there also is a misunderstanding that the MOST form is a legislated order for healthcare professionals to follow, including EMS. And it doesn't have EMS protocols to follow, even when signed by a physician. It doesn't offer immunity for providers to follow. There's not a lot you can hand me as a physician that's signed by somebody I've never met that's going to have me alter standard protocols about how I would care for somebody. And that's where the POLST program took a lot of time to put in place, but it provides so much around the program to be sure that when someone's presented this form, they know what it means and they feel comfortable to honor it, and they know they're legally protected to alter what would be their usual algorithms to now do an alternative algorithm. And the MOST form wasn't set up with the program behind it or the legislation. And so the transition time from MOST to POLST, it really is, everyone in Alaska with a DNR should really have a POLST, and that's a Comfort 1 to POLST transition. And then for MOST, I think it depends on how you're using it. If it's an in-facility order that you need, that you use the POLST for the DNR and to have the portable orders around the other scope of treatment, then you can look at what are you doing for in-facility orders. And would that be to reference the POLST? Or would that be to have a separate in-facility order set that if you were to use the term MOST, we're recommending to not have it look so much like the POLST form, because you could see how that really is, that really has some liability and some opportunity to be miscommunicated. There is hope that POLST will have there's work to have a registry someday too. So even that would make it even more powerful around making sure that all healthcare professionals in emergencies can know somebody's wishes. So I think that POLST adoption is clear. POLST is an active legal order now. When the reference document and the regulation was passed, it, the POLST was out there and it was discoverable, and some have been completed and EMS is following them. And so that's what we're telling healthcare professionals too. If you're presented a POLST form, it's an active medical order. So as a facility to think now, how are we going to start as we receive POLST forms, implement that into our in-facility orders and to confirm those wishes, to know what it is, to know what our responsibilities are around that. And then after that, you're going to think about how do we, when we have these conversations, how do we start implementing POLST and stop using Comfort 1 as we do them new? And you have time to adopt to your choice around, do I talk to someone about a Comfort 1 or do I talk to someone about a POLST? There's leeway because both forms are going to be honored. But the Comfort 1 is intended to sunset by stopping the supply of Comfort 1s, which will happen in June 2022. So I hope that helps give people some idea of the timeline and the pivot.
Yeah, I appreciate you reinforcing that, Ursula, that a Comfort 1 that shows up no matter when, no matter where, will be honored if that's the only form that you have. I appreciate Mr. Thibodeau's comment that they've used the form, and I assume you mean the new POLST form, at Denali Center and have been able to easily transition from MOST to POLST. So there's proof out there that it can go well and it can be well used in those settings. But if there are any questions at all about the transition and about what's valid, and I think Jeannie and the group are going to be a great resource.
One more issue that I have heard, and I think it may be worth emphasizing, is that the POLST form, it says healthcare provider, but Alaska statute requires that it be a physician. So even though it says a licensed healthcare provider, which I know we have advanced practice providers that are licensed, statute does require it to be a healthcare provider. And Ursula, I don't know if you want to speak a little bit to this, the difference between the people who can have the conversation and help guide the process.
Right.
Don't necessarily have to be the one who sign it.
That's right. And that's why that part on the back that contains the how that conversation took place, who was there both from the family and surrogate side, but also who was there from the health care team side to really help facilitate that conversation. I know that our hospice teams, many times it's the nurse or the social worker, and they're giving a call to the doctor, and that verbal order is being noted on the POLST form so that it's an active form. The co-chair of our POLST in Washington is a hospice medical director, and he says that their teams actually go out with two forms, and they sign the verbal order and leave one in the home, and then they bring one back and he signs it, and then they take his signed one back out to the home once it's been copied and uploaded and given to all the places it needs to give. So I think the fact that verbal orders, especially for facilities and for places where a nurse practitioner or PA might be actually doing the admissions, I think that verbal order signature is going to be a great way. And then just follow your procedure about following up and getting the physician order on that document. In Washington, we actually had a very similar circumstance where, as we launched the POLST, we said it's fine for PAs and nurse practitioners to sign it. And then actually it was quite a while later that we discovered that the EMS only accounted for orders that were written by physicians, but there was a standard of care process by which they could actually honor orders written by other practitioners. I think that I think it will work itself out. But I think it's important to realize right now you need to always make sure that at the end of the day or the end of the week or whatever it may be, that POLST form ends up with a physician's signature on it. But the verbal order on it, it says right on it that verbal orders are valid. And so if someone has a license to take a verbal order, you're going to be able to make those orders pertinent in the moment if a nurse practitioner or PA or even the nurse in the facility are signing them. Does that help, Jeannie? Yeah.
Yes, thanks very much. Well, we are out of time unless there's one more question or comment from anybody. But we did just put the information on the next two webinars in the chat. Check on the webpage, akpolst.org. And thank you everyone for attending. And thank you to Charmin and Ursula for presenting today. And that will be the end.
Thanks so much, everyone.